Okay. So someone to lead us in our program, volunteer from the physical participants.
May we give a prayer? Amen. Our Father, Lord, we give you all our great Redeemer. Receive our thanks and our praises this morning for this gift of this opportunity to give us to gather here and earn a few more skills in our practice, so that God is under the scale of our own way to optimize and get the delivery of our missions. This is a responsibility of the stone upon us in various facilities where we serve. Bless us, God, and in the presence, abundance as we proceed. Give us all our thanks.
Okay, thank you. Thank you for that wonderful prayer. We want to dive into the agenda for today. I want to share the agenda before I allow Lulu to start the presentation. Agenda. So we'll be having some few activities that will take approximately 3 hours. I'm trying to look for the agenda. Let me share it here. Here, share my screen. This is the agenda for today's meeting. So we will skip the introduction part, especially for the physical participant for now, so that we save time, but we will do it later when all of us are around. Then I hope you can hear us. Anyone? Someone is speaking?
Yes.
Let me mute. Good. So we will then start right away, probably by 9:10, a sensitization on the ongoing HIV PMTCT RRI. I know we have been informed of the ongoing RRI. So Lulu will be taking us just a snapshot of what we'll be covering in the next, I think, 90 days when it comes to the RRI. Then we will go to another CME that will be covered by Dr. Zomo. That is management of cryptococcosis in HIV. Then after that, we'll have a Q&A session. Then we will have a BRT result interpretation for 2 facilities, that is the Doratu in Kasarani and Mata Hospital. Then we will have our CASCOS for Nairobi and Kajiado do the closing remarks and a way forward. So that will be our lineup for today. Without much ado, I want to stop sharing. I invite Lulu to take us through the CME. Welcome, Lulu.
So, good morning, everyone. My name is Lulu Ndapatani. I work for USAID Fahari Ajami as the PMTCT focal person. For the purpose of this presentation, we would like to just look at what has led us to the current RRI for PMTCT so that we can be able to recover on some lost processes. But just allow me just a second to make sure that my presentation is on presentation mode, and then we will proceed. Just give me a moment. able to get it onto presentation mode, though I can see that it's that way. So we'll very quickly look at the background, rationale, objectives, and the focus area of interventions. And then we'll just switch briefly to look at which are the missed opportunities that we have as Nairobi County and what each one of us really needs to do so that we can gain traction in this very important area. We all know, I think this is just a bit of background data on in regards to why we are doing this RRI process, and also post the RRI, we need to remember that as much as we have an RRI in the next 90 days, we need to gain traction. We need to gain traction in terms of
Lulu,
moving forward.
Lulu,
Yes, Chris.
you're not on slideshow. Maybe you can.
Yeah, if I put it on slideshow, the presentation is not moving.
Okay.
Yeah, but I think we are all on background. We are all on the background slide. So just allow me to present it as is. If I put it on slideshow, my slides are not moving. I think it's the presenter view or something.
Okay.
Yeah. So we know that Kenya is actually among the countries that are shaping the global alliance really to end pediatric HIV infection in children by 2030. So we know there are about 12 countries in the global alliance, and generally these are just countries within sub-Saharan Africa that are contributing to about 90% of all pediatric HIV infections, and Kenya is amongst them. And what the global alliance is all about is ending pediatric HIV by 2030. But we also know that as much as the global alliance, a deadline of 2030, our president committed to a deadline of 2027 in terms of Kenya achieving elimination of pediatric infection for HIV by 2027. So we have a shorter deadline really, because we hope that we are not going to, I think all of us are committed to not disappointing our president by that commitment that he made to the Global Alliance that Kenya will do this by 2027, though we know that the global deadline is 2030. So with that, then we have to really accelerate efforts towards ensuring that we have a reduced mother-to-child transmission of HIV infection, and we also have HIV. Our children who are living with HIV are on the optimum care in regards to making sure that they are virally suppressed and they are achieving, their growth and development milestones. So we know that we also have a suboptimal HIV care and treatment program, and we have a pretty high mother-to-child transmission rate as a country. So our mother-to-child transmission rate in Kenya is 8.6. We will look at what our transmission rate is as Nairobi, though it's lower than a lot of the counties, but still it's not a transmission rate that we are really proud of because of the number of HIV positive children that we continue to diagnose every month when we do those PCRs. So we have a current ART, and this is national data. We'll look at Nairobi data in just a bit. This is national data. We have, let me do the other slide, it's a bit clearer. We have 86% coverage of maternal ART. So what that means is that out of all the women that really should be on antiretrovirals to prevent mother-to-child transmission, only 86% of those are on ART. So what this means is that we have a shortfall as a country of 14% in terms of ART initiation for our moms that present themselves for ANC services at the first time at ANC1. We have an also very suboptimal infant prophylaxis at 75%. In fact, infant prophylaxis is struggling in all counties compared to maternal ART. You find that there are some counties that have a very good coverage of maternal ART, but they have very poor coverage of infant prophylaxis. While we know that the guidance is that when you're starting, you're initiating ART at ANC1, or a client is presenting themselves as a non-positive at ANC1, then the infant prophylaxis should be offered at that time and should also be documented. 96%, not very bad, but we want it to be at 100%. Remember, any viremia for a pregnant and a breastfeeding client, any viremia is bad. Even if that viremia is, maybe we are saying there, we can see 50 copies or we can see 25 copies, which is lower than the national threshold for suppression, but really any viremia. So generally for pregnant women, they should not present with any viremia at all. So we should be at 100% viral suppression, which currently we are at 96. I think Nairobi also just at the same level in terms of viral suppression for pregnant and breastfeeding women. Mother-to-child transmission rate, Kenya 8.6, Nairobi slightly lower than that. And then CAL HIV on ART 87, and then CAL HIV that are not optimized on DTG regimens at 92% as a country, and we should be at 100%. So we still have pockets and pockets of facilities, even within Nairobi, that have children who are not on optimized regimens, although I know there's quite an intensive exercise that was done just recently to make sure that we account for all those children and that we are able to report those numbers correctly. So we want to make sure that for us to be able to achieve mother-to-child, elimination of mother-to-child transmission, we know that as the entry point to this service, then timely diagnosis of HIV positive pregnant and lactating women is key. So you will see our data for 2022, we had a significant number of missed opportunities for testing as Nairobi. So that is bad. Because if you don't identify a pregnant woman who is living with HIV or a client who is breastfeeding who is living with HIV, then you have an increased risk for transmission because you're not able to offer antiretrovirals on a timely manner. And optimization. Yes, Chris? Okay. And then, of course, optimization, we want to make sure that all our clients are on a TLD regimen because we know the benefits of that regimen. So at least our moms should be on that regimen as what is considered to be the optimum regimen for achieving and sustaining viral suppression. And then for our children, again, timely diagnosis, ART initiation, and optimization of regimens also is critical for preventing early mortality. We know that children generally don't do as well as adults if we delay any ART, and we struggle here as Nairobi County, we have quite a bit of struggles. Once we identify children who are living with HIV, we are not able to very quickly put them on ART like we do for our adult populations. So this is our call to action for all of us who are represented in this conversation this morning, that we need to make sure for every area of service delivery that we are covering and we are dealing with, whether mothers who are pregnant or are breastfeeding and are living with HIV, or we are dealing with children, then we have a role to make sure that these children, receive the best in terms of care from us, and our mothers receive the best in terms of care from us, so that we can end this cycle of pediatric HIV infection that we continue to see every day. So we know that the KDHS results, the final report I think was just released last week, told us that over 98% of pregnant women in Kenya attend health facilities for at least one ANC service. So this is good. For a country like ours, this is good, because then what that means is that there is opportunity for you to offer your PMTCT services and to offer your antiretrovirals for women who you will offer the HIV test to. So the women are coming, the women are actually coming. Then what remains is that when they come, are we giving them the best care that is required based on the guidance and standards that have been given by MOH? Other countries really have much lower than this in terms of ANC1 attendance. So we need to use this as a platform to get our services to 100%, because we have just a very small proportion of women who do not present for ANC1, even in counties that are hard to reach. Like Nairobi, our coverage for ANC1 is over 100%. So that's a low-hanging fruit for us that we know we might probably not get into looking for those women because they will come. What we need to ensure is that once they present themselves, then services are available for them and their infants. And then we know that from our routine data, if there's someone who needs to mute, I think that's Joyce. Joyce, kindly mute yourself. So we have, we know that from our routine data, that is February 2022 and March 2023, we have significant missed opportunities for both access to PMTCT services and CAL HIV care. And we will look at that. We will look at just a bit of national level slides, but we'll also look at Nairobi performance to see where we can close this gap as part of the call to action during this RRI. So for the national data, we had 345,000 women who missed HIV testing at ANC1. pretty significant. We know in Kenya we have about 1.2 expected pregnancies annually. So if we have that number missing ANC1, it means like about more than about a quarter, yeah, slightly less than a quarter of the pregnant women who presented themselves for fast ANC missed HIV testing services. So what this means in hindsight is that they will miss an opportunity to get onto antiretrovirals if they are HIV infected. Their infants will miss an opportunity to get on infant prophylaxis if they are HIV infected. We will miss an opportunity to do viral load monitoring and mother-infant baby pair follow-up throughout that duration of care. And then, of course, you have the missed opportunities for heart, significant, yeah? So this means that out of the ones that were tested, which is about 70% of the women that came to Kenya, to ANC services in Kenya, out of now the ones that did receive the HIV test, 4,180 missed antiretroviral. So this is generally a system failure. So we say that sometimes we say, oh, you know, clients declined antiretrovirals and many other reasons that we give for not for our clients not accessing this service. We say, oh, we didn't have, we had missed, we didn't have AZT, we didn't have nevirapine. We gave the nevirapine syrup or the AZT syrup in third trimester. So the way our reporting in Kenya is designed, if you don't report these interventions at ANC1, even if you do report these interventions, I mean, you do provide these interventions at any other subsequent ANC visit, then you're not able to capture that data. So we call it really a missed opportunity for treatment. And then we have quite a number of CAL HIV that are not on DTG-based regimens, 2,499, pretty significant. Living with HIV, 79%. So we have 12,000 children in Kenya who do not have a most current viral load for their management or for the management of those children. So we know that yes, we have had quite highs and lows in terms of commodity situation last year. In 2022, they were pretty significant. However, when we need to prioritize, like for instance, if I have 20 pieces of commodities that I need to prioritize for viral load, which population would I give to first? I guess that's the question that we need to ask ourselves. Which population would you give to first? Because our adult population have better viral load uptake than that. Yet our children, you know, they really continue to suffer in this area. We say that sometimes they're in school, or you know, the caregivers are not giving them, are not bringing them to the clinic on a regular basis. Some of the reasons that we know exist within the health facility as part of the challenges why children are not optimized on these services. But then that means for us now then is that if we have all these challenges, then what systems are we putting in place to make sure that as much as we know that our clients do have challenges, but how are we supporting them so that their children are at 100% in terms of delivery of this service and delivery of the care that they do require? What community systems do we have where we can be able to trace children? We can reach out to the schools, probably our children are in schools. What systems have we put in place as caregivers to ensure that we are at 100%? And then, of course, you have viral suppression for pediatrics at 89%, which is much lower than what we see for our adult populations. Other counties for their adults, they are at 98% viral suppression, 97% viral suppression. I think the counties that have very low viral suppression in Kenya have for adults is ranging in somewhere in the 90s. But for the children, we are actually at 89%. Of course, with other counties being high, I think Nairobi, we are at 91%, but it's still not good enough, even if we have crossed the 90% mark. So there was also an exercise that I think quite a number of you participated in last year, the service quality assessment that was done for PMTCT. And it was realized that there are a lot of commodity stockouts, you know, they continue to persist. And this contribute to significant gaps in terms of missed opportunities for service delivery. And then we have still facilities that are using very old data tools, and they are photocopying tools or they're improvising tools. So if you're not having the most current data tool, which maybe requires you to report in a certain way, what that means is that the reports that you will share to the national program will not meet the standards as have been put by MOH. So again, as we support facilities, these are the things that we need to look at critically. What are they using to do their reporting? What kind of report have they put in their MOH 731? Is what is in the MOH 731 or what is being transmitted upwards to the national data warehouse exactly as what we have at the health facility? So that when you're looking at that data, you don't say, oh, probably that doesn't look like data for facility X. So that's the reason why people generally do data quality assessments to check what the data sources are at the site, whether they speak to what we have as the information is transmitted upwards. And as we transmit information upwards, how are we utilizing the data that we have posted to really make decisions about the care of our clients as they come to us? And then, of course, we know that we have had a reduction of more than 50% for mother to child transmission in Kenya. We started with highs of 27%. Right now we are at 8.6. We know that a couple of years ago we went back to about 12. But our desire is that we maintain that trajectory and we don't fall back. And for us to maintain that trajectory, then all of us have to be in the same page in terms of the priorities for our mothers and our children and the follow-up that we need to give going forward. So this year, there's an RRI that has been proposed so that we can be able to mop up all these missed opportunities and provide them with services. And for the ones that have already mopped up the missed opportunities, we are hoping that we will be able to report those onto the national data platform so that at least we can be able to align those numbers as part of our catch-up strategy to ending HIV in children by 2027. So for PMTCT, what we need to do going forward is to eliminate missed opportunities, and we need to put in a lot of effort to strengthen longitudinal follow-up of our mother and infant pairs. We know that the Ushauri platform is going to very soon have, if not already, a longitudinal follow-up for our mother-infant pair. So you're able to put in the mother and the baby together, and then you follow them up together and make sure that you're able to account for each of the clients that you have who are considered to be PMTCT clients in your health facility in terms of outcome. And then, of course, for pediatric HIV, we need to be aggressive in terms of case finding. So generally, we have stagnated in terms of case ID for children. We are not diagnosing as many children who are living with HIV infection as we think we should. Evidence really says that we have not optimized in this area. While we do know that PMTCT services are working and we have a reduction in transmission, but still we are not able to conclusively say 100% that we have looked for all these children and we are not able to find them. So probably they do not exist. So these children are there. And one of the low-hanging fruits that we have really is how many children have we tested of our index clients who are within our CCCs. So that's a low-hanging fruit. Out of all the newly diagnosed clients that present themselves every day, we diagnose within the HTS service delivery areas, how many of their children have we line listed? How many have we tested? What testing strategies are we using to make sure that we reach out to these children? Because sometimes they are in school, like now children are back in the school cycle. We expect them to come in August. So we might not consistently always get the kids as we desire, but what strategies are we putting in place to make sure that when the kids are available, then we can access them and we can test them? So the objectives of the RRI is to reduce the missed opportunities by 95% across all service delivery areas. And for the missed opportunities, we're talking about maternal HIV testing, ART, EID, infant prophylaxis, and then of course, optimization of regimens for our children and viral load monitoring and suppression for our kids. And then, of course, we know that with this RRI process, we need commodities, and I know our national program is working tirelessly to make sure that we have these commodities during this period so that we, it doesn't add up to the challenge that we have for missed opportunities of services because we did not have sufficient commodities in place, whether we are talking about HIV testing kits, or we are talking about prophylaxis for infants, or we are talking about EID commodities that really have been persistent for a very long time. And then, of course, data, we had quite a lot of gaps. When we looked at the HIV optimization for DTG, a lot of it was actually misreporting. So we need to be very keen about the numbers that we are posting onto MOH 731. How are we verifying that what we have posted on MOH 731 is the correct situation that we have in the health facility? Some of the facilities that are in this RRIs, because they misreported their HIV positive clients who are non-positive. So you have like 25 clients who are non-positive. A client who is non-positive when they are presenting for ANC1 is a client who is already on antiretrovirals, and that needs to be reported as such, even if you're not the one who started that ART. So that when you're matching the numbers of HIV positive moms that you have, new positive plus non-positive, then you have all of them as well being on ART. So simple things that we can do going forward within our health facilities to make sure that we strengthen these aspects. One aspect is service. The other aspect is documentation and reporting. And then TAT of less than 10 days for both our EID and our viral load. And then of course we need to look at issues of accountability and partnerships towards ending HIV. We know that as a health fraternity, we probably don't have all the answers and all the responses. We need other stakeholders to really join, especially in terms of demand and communication and advocacy and matters reducing stigma. Yes, we need a lot more than our healthcare workers to help to close on these gaps. So this is what is being proposed as areas of interventions for the RRI. So we have different areas. Of course, there's going to be a lot of capacity building of healthcare workers, and what we are even doing now, and we will continue to do on this platform. So stay tuned for the links as they are going to be shared by our coordinator, Chris. We will use this platform a lot to communicate and to just build capacity of our healthcare workers so that we can all be confident in terms of providing care for our mothers. We can all be confident in terms of providing care for our children. When you diagnose a child with HIV infection, what do you need to do? When you're following up a mother who is a PMTCT client, what do you need to do? Some of us know it very well, others probably not. So we'll use various platforms, and this being one of them, to just build capacity for all of us so that we are all on the same page. Of course, there is the issue of supply chain, which is a big factor. We hope that our national program will be able to front load all the sites that are participating in this RRI with commodities so that we don't lack. So for Nairobi, we have 123 facilities that at least listed some kind of missed opportunity for one of the services that we are talking about. Actually, the largest number of sites in the entire country, 123 facilities. So we have quite significant work that we need to do. Of course, data reconstruction. Another, we will discuss the tools. So stay tuned for that. Today we'll not look at the tools in detail. We're just looking at the overview and the numbers and the tasks for each one of us, and then optimization for those services. So if you identify a client with a missed opportunity, one of the things is that you need to offer the service. And if the service had already been offered, like would be the case for some of our facilities, then we will document and report that service on the Kenya Health Information System. They have tools that they have put there for the RRI, so that we can be able to account for every client, every child who was listed as a missed opportunity. And then, of course, we've mentioned the linkage, and of course, not forgetting advocacy, education, and demand creation for PMTCT. The reason really why we do demand creation is because there's that role that we have as healthcare worker, which is to provide certain minimum package of standard of services. And then we have the roles that are for our clients. So when we are giving education to our clients' duty is to make sure that they take the medication as advised, they present themselves for clinic as advised. If they are having certain challenges, what are the support systems that are available for them and how do they seek those ones? So we have the healthcare worker roles and we have client roles. So that's what advocacy really is all about. And then we also have roles of other stakeholders who generally, control certain areas and aspects of our clients' lives. Employers, for instance, they have a role in terms of looking at whether the people that work for us really have the best care, receive the best care based on whatever conditions that they are struggling with as individuals. So these are the indicators that we will look at. Of course, we have differences between what was presented in KDHS and what we are seeing on the Kenya Health Information System. So it means we have pockets and pockets of missing data. And we have also other facilities that probably are not completely doing any reporting for PMTCT. Like we do know that we have in Nairobi a certain set of facilities that completely don't have data sets for MH731, yet they are providing ANC services, and probably to a large extent, they are also providing HIV testing services for these women. Yeah, so a situation that presents itself cuts across the entire country. HIV testing, ART for mothers, infant prophylaxis, and then of course, early infant diagnosis and viral load and optimization for children. We know that as there's an area that is a very good opportunity for us to prevent new infections, but we have not optimized, and that is the HIV prevention package for women who are HIV negative. So women who come for ANC, come for PNC, come to the labor and delivery, and they are HIV negative, and they are probably at risk of HIV acquisition. What kind of services are we giving them so that we prevent that new infection? We have seen situations here in the health facility where we have clients who come at ANC, either one or two, they're HIV negative, but by the time they're coming for their 6 weeks PNC visit, then they're HIV positive, or 6 months PNC visit, then they're HIV positive. It's likely because we missed to pick that risk at ANC1 and we failed to offer an intervention to prevent that infection for that client, whether it's PrEP plus other additional prevention interventions, then that's a missed opportunity, yet it is a low-hanging fruit for us because we offer testing for all ANC1 clients. We have majority of our ANC clients, ANC1 clients being HIV negative. However, how much have we ascertained whether there is risk to HIV acquisition? And once we do ascertain whether there is risk to HIV acquisition, how well are we going to doing in terms of offering that package of service, which includes PrEP, and then of course nutrition being a very key factor in terms of ensuring that our children grow up, our children who are on HIV grow up and they thrive. So we have this, we'll not look at this slide in detail, but generally what it says is that we have 1,688 facilities that have been flagged out by our national program as facilities that presented with a missed opportunity for one of those services that we have talked about earlier. It's either a missed opportunity for ART or prophylaxis for the infant or maternal HIV testing, or optimization on DTG for our pediatrics, and quite a lot of these facilities are in the ASAL counties, but of course, as we said, Nairobi is a significant county in terms of the numbers of facilities that presented themselves with a missed opportunity for ART. So this is the implementation model that is being proposed by our national program. Of course, we will have the national team that is going to do a lot of the technical assistance, the monitoring, and issues that are related to commodity security, advocacy, communication, and social mobilization. So we have various teams that are doing different things. We have the team that is looking at matter service delivery, which is generally what we will look at the end of the RRI and the steps in between. And then we have other teams that are looking at what advocacy and communication material needs to go out there. How do we raise demand or create demand for this service in the entire country? And then we have now those other steps. At facility level, our biggest role at facility level for those of us who are doing service delivery is to make sure that we implement the intervention. We implement the intervention. So if the intervention is to categorize our missed opportunities, then we do that. Once we have categorized our missed opportunities, we fill in the patient locator information, and then we trace those clients and bring them back to care to care, and services are offered, and then that service is documented subsequently. And then of course, community engagement as we see. So I want to shift gears very fast. The rest of the information for the RRI really is things that we can read on our own. So let me shift gears very quickly so that we look at Nairobi performance, yeah, in regards to what we presented as our data for. So just allow me to stop sharing my screen so that I can put up the other presentation that is just briefly speaking to the performance for Nairobi and which sub-counties have, the largest missed opportunities. Of course, I'm sure you have received this information through your subcast scores in relation to the facilities that contributed to this data. Yeah. All right. So this is our Nairobi. So now this is bringing the conversation closer home. We will look at our overall county performance. I think that's the most important bullet number 1 and bullet number 2. Of course, we might not focus a lot on the commodity stockout issues because we issues that we have been grappling with, but we'll focus on the action points, what we need to do as Nairobi so that we can get back on track. So our situation is that we have a prevalence of about 4.4%. Of course, women having a higher HIV prevalence than men. We have about 165,000 people who are living with HIV. That's all age groups. So we have, out of that 165,000, 158,000 are adults and 7,000 are children. So a lot of us have interacted with this slide previously. I think what is important for us to note is that every year as Nairobi County, we have an estimated 425 children that we identify as newly HIV infected pediatrics in Nairobi County. A lot of these pediatrics are identified through EID testing between less than 2 years, and then we have another significant population of the children, about half, that are identified through other HIV testing modalities that we have at the health facility. So this pediatric HIV infection is what we hope to end by 2027 as Nairobi County. We want to have no children at all being diagnosed with HIV infection, especially where it's mother to child, and 0 to 14, really a lot of it is usually mother to child transmission. And then we have this other pocket of young adolescent and young people that contribute to 25% of all new infections in the country. And of course, now this is where advocacy and PrEP and HIV prevention interventions really come in as a role to end that cycle of new HIV infections as we go forward. So this is our PMTCT need based on the HIV estimates 2022. We have a PMTCT need of 7,217. What generally this means is that in Nairobi, if we are to say that we are at 100% service coverage, we need to identify 7,217 women living with HIV. A big proportion of these women are non-positive, and then a slightly lower proportion of those are new HIV infections. And then we provide those mothers with antiretrovirals. So when you look at our ART coverage as Nairobi County, it's at 98%. Yeah, it's at 98%. So it's not as good as we desire. It should be at 100%. So every female that presents themselves to a health facility should be reached with PMTCT services. And then we have mother to child transmission rate of 5.9%. So Nairobi has the lowest mother to child transmission rate out of all the subnational units in Kenya. However, a round off of 6% in terms of MTCT rate is still not good enough. We know we can get to an MTCT rate of even 2 if we do all these interventions and we sustain them over time. We can get to a MTCT rate of about 2 or even less than 1, like other countries that have a similar HIV prevalence and social circumstances like we have. And then those are the numbers of children that we have, 0 to 14 and then 10 to 14 years. So I think this is an important slide for all of us. And this slide is looking at what are the numbers of missed opportunities we presented as Nairobi County. So this is just generally data that we entered into our Kenya Health Information System through our MH 731, and also data that has been picked from our EID viral load national website, where when we send in samples for EID, then they are logged onto that website. There's a lot of information you can access from that website. So this is what we have. So Dagoretti now, so we have, so the sub-counties have been collapsed, so Dagoretti we have north and south of coast, as now here it appears as one sub-county, contributed to largely a lot of the missed opportunities that we have for maternal ART and infant prophylaxis and infant HIV testing. So I'm sure for those of us who are in Dagoretti sub-county, we have received communication from our sub-CASCO telling us that we need to develop line lists for each of these missed opportunities and account for each of these missed opportunities. So Dagoretti presented 7 children that were not optimized on DTG. We have 16 children that are not suppressed. We have 12 pregnant and breastfeeding women that are not suppressed. We go to Embakasi West, 477 women missed HIV testing, 31 missed maternal ART, infant prophylaxis, 131 children missing. And then, of course, Embakasi West, significant numbers of CAL HIV unsuppressed at 57, and the pregnant and breastfeeding women unsuppressed at 68. Then Embakasi East, significant numbers, 1,800. Actually, Embakasi East is the sub-county that has the highest number in terms of missed opportunity for testing for clients at ANC1 at 1,823. So the facilities that are sorry, yeah. So there's sorry, there was a monkey. Sorry, yeah. So Embakasi East is 1,823. And then we have now the rest of the sub-counties, as you can see. We have this excellent sub-county here, Westlands, that did not have any missed opportunity for HIV testing for pregnant and breastfeeding women. I think we need to congratulate Westlands. This is the kind of data that we want to see going forward as Nairobi County, where we do not have any sites at all. I don't know if it has taken anything. That we need to see as we go forward. Even look at their maternal ART, only one client missed. Yeah, infant prophylaxis, again, one client. DTG gap, only 2 of their pediatric children are not optimized. And then they have quite a bit of data. They have quite a bit of CAL HIV that are not suppressed. And then also fewer pregnant and breastfeeding women not being virally suppressed. So we need to, generally, as we say, going forward as Nairobi, this is the kind of performance we would like to see in all our health facilities, that once clients present themselves for service, then all of them receive the service. Yeah. So this, what you can see, this is an important slide. So allow me to take like about a minute or so. These health facilities that have contributed to this data here are the ones that are going to fill in a lot of the tools that we have for RRI that we will not share in this meeting, but we will share in a different learning space, and also sensitize the teams on how to use them. So the more missed opportunities you have generally, the more work you're going to do during this RRI. The less missed opportunities you have, like our brothers and sisters who are in Westland Sub-County, the less work you're going to do in this RRI. What you will be focusing on is sustaining, the good things that you have been doing going forward. Sustaining the good things that you have been doing going forward, so that you continue to maintain that trajectory of service delivery. So Westlands will get a lot of focus. Their focus really will be to optimize these 2 children if they've not already been optimized, get their CAL HIV to be suppressed through the systems that we have at facility, and get the pregnant and breastfeeding women to also be suppressed, and beef up, their systems for longitudinal follow-up for our children. But they will not be going back to struggle to look for which health facility is this that did not test their pregnant women who presented themselves to ANC1. But let's say now our counterparts in Embakasi East will have the largest work in terms of looking for the missed opportunities for HIV testing at ANC1, because they have 1,822. They have 161 infants that they did not document as having received antiretroviral therapy. So what I would want to say in terms of documentation of infant prophylaxis, I know we have had situations where we have had 1 or 2 of those. So we have 1. We probably don't have, we've never had a situation where we have both missing, but we have 1 missing. So we have either nevirapine stocked out, or we have either AZT stocked out. But if you have 1 of those commodities, and you issued one of those commodities, you can as well go ahead and report that, because that child really did receive infant prophylaxis, though it was not what we are recommending as the dual therapy, which is AZT and nevirapine, but you gave one. So again, we need to look at the way we are documenting our infant prophylaxis. Sometimes you say, because infant prophylaxis is of short expiry, we are only going to give the women who are coming in third trimester, and we leave the women who are coming in first trimester because the prophylaxis is of short expiry. And then we have a gap there. You had better give that prophylaxis that is of short expiry and replace it when you receive long expiry prophylaxis, as opposed to giving completely nothing. So some of these scenarios is what we really need to support our healthcare workers to make decisions at the health facility. I can imagine if I'm the healthcare worker who is at the site and I'm presented with that situation and I probably don't have an opportunity to consult, I will make the decision that I think is the best for that situation at that time. However, might probably not be the best in terms of care for that child going forward. So we need to be very supportive, really, and hold hands for our healthcare workers so that they feel confident that, yes, I had a short expiry AZT, I had a short expiry nevirapine, I gave, with a note that I need to replace that prophylaxis when I have commodities that have good expiry, and then I can ask the client to bring back. That way, one, you will have closed the documentation gap, and you've not left the client without any prophylaxis. As opposed to where we say we are not going to give, we wait for the client to get to third trimester or to get to labor and delivery. If supposing they don't come to your health facility for third trimester, or supposing they don't present themselves to your health facility for labor and delivery, or yes, probably they present themselves to a health facility during labor and delivery, but they don't disclose and say that there are clients who are living with HIV. How would you identify those clients as clients who probably need infant prophylaxis to be issued? So you had better give them medication and tell them that for this medication, it expires on 28th of, like now we're in July, right? So it expires in August or end of September. However, I will call you back immediately I receive. Clients are likely to come back if you give them something than if you completely leave them with nothing. So it's a delicate balance of situation. Like for me, if I go to a health facility, I'd rather be given something than I'm told we don't have now, come later for you to come and get. So which situation is the client likely to come back for service delivery? Where they have something and then they are told we might call you to change, or where they have nothing. So those are some of the decisions that we need to think about very critically when you are providing services. So as I close, so there was this exercise that was done and a lot of you participated in this exercise in Nairobi. We had presented 28 missed opportunities for optimization onto DTG-based regimens as Nairobi County. And out of those 28 missed opportunities, the ones that were truly clients who are not being initiated on a DTG-based regimen were 4. The 24 were all data errors. So we can see the gravity of that situation. 24 of these were all data errors. And we have the facilities there. You can see the names of the sites. They were all data entry issues. So what this means is that those children were on a DTD-based regimen, but the way we reported it also, this is where the national program now says we have children who are on nevirapine, and we all wonder, where are these children on nevirapine? We don't have any children on nevirapine in our health facilities, but because of the way we have reported it, then that is how it is captured. So we did do this exercise and found that these children are all on a DTG-based regimen, but that's not how it appears on our national data because we reported something else. So these are the gaps that we need to close. Once we share those data, once the national program opens that Kenya Health Information System for reporting the RRI activities, then we need to make sure that this data is dealt with and it is changed. All right. Let's look at our maternal cascade. So now this is where we get the numbers. Like, we get the numbers that are missed opportunities. So for Nairobi this year we have a higher need. Based on the HIV estimates, we have a higher need for PMTCT, mostly because we could always consistently identify a lot more than we have. So our need for PMTCT was adjusted. You remember 2022, we had 6,000, now we have 7,000. So out of the 6,000 that we had, we identified 6,883. So we identified more than what we were given as the national estimate. But even with the high edit and the identification as Nairobi, we missed 489 maternal ART. So we did identify. Yes, we know that we had challenges with HIV testing kits, but we did identify. So out of the ones that we did identify, 489 did not get prophylaxis. So the question you want to ask yourself is that, did you misreport? And the facility list has been shared by our subcascos. Was it a misreporting issue, or truly those clients did not access antiretrovirals? If it was a misreporting issue, then we very quickly need to change that and document it correctly. If it was an issue where clients did not access antiretrovirals, then now the service delivery aspect of it comes in, and we very quickly look for those clients and we make sure that if they now got the antiretrovirals later, we report it as such. Look at infant prophylaxis, 942. So out of the 6,838 women that were diagnosed with HIV infection in Nairobi, 942 of those mothers were not given infant prophylaxis. So what are we saying about our quest to achieve elimination of mother-to-child transmission? Gold standard, we know, for elimination of mother-to-child transmission is that once you have identified clients who are pregnant or are breastfeeding and are not on ART, you initiate and you sustain. That is the gold standard for prevention of mother-to-child transmission. So if we have continued to have pockets and pockets of clients that are not accessing those two services, and yet they presented themselves to a health facility, truly we can go ahead and say that this was a system failure. So it's not a client challenge, but it's a health facility system challenge. So we look at what are the systemic gaps that we had as Nairobi that made us see all these women, diagnose all these women, but not provide any antiretroviral prophylaxis. And then, of course, we have challenges with HIV positive deliveries. We need to always ask our clients, where are they delivering? Are the places where our clients actually delivering facilities that have posted their data on KHIS? Because KDHS is telling us as Nairobi that we have a very high hospital delivery rate at 99%. I think 99% of all clients in Nairobi deliver within a health facility. So that question begs the question that maybe at the facilities where they are delivering, are they reporting whether those women are HIV positive? So again, do those sites where our clients are delivering have PMTCT services or services for prevention of mother-to-child transmission? Because if they do not, then probably even they would not find out whether the client is HIV positive or not, so that we can close those gaps. And then, of course, now this is our data for March 2023, which is very recent, very recent. So we are 25% traction in terms of achieving identification for our PMTCT clients, very good. We've had quite a bit of stability with the HIV testing commodity, so we hope that we will not continue to present missed opportunities for HIV testing going forward. Out of the 1,700 women that we diagnosed as HIV positive, 113, we didn't give 113 prophylaxis. So if you count this 113 and you times that by 4, if we don't change this traction as Nairobi County, if you times that by 4, we will get to 400 by end of year, which is exactly what we want to avoid. We want to be in a space where if we are reviewing the data for June, for just ended June, this quarter that has just ended in June, then we don't have 113 missed opportunities for ART. So let's look at our data very closely at health facility. Let us look at our data very closely. If we didn't give prophylaxis, then can we look for those clients and make sure that prophylaxis is given? If it was a documentation issue, can we close those documentation gaps by the support that we will give? Same for infant prophylaxis, yeah? 129, if we continue with the same trajectory, we will get to about 500. Yeah, we will get to about 500. It will be slightly less than what we presented last year's 942, but still not good enough. 500 women missing prophylaxis for their infants is a significant number. I know we had the outages of AZT, but we did have nevirapine present. We did have nevirapine. So we need to give that nevirapine and document that prophylaxis has actually been given, as opposed to giving that nevirapine and not documenting that prophylaxis has not been given, or not giving that nevirapine because you're waiting until the day you have AZT. It is better you give that nevirapine than to give nothing at all in terms of prophylaxis if you have only one commodity available for you at the health facility. And then, of course, deliveries from our HIV positive moms are safe. So these are some of the corrective actions that we are proposing as Nairobi County. we need to very closely look at the data that we are putting onto MH731. And this is at facility level. Let's not wait for a situation where our sub-CASCOs or our HRIOs or our sub-county public health nurses are calling and asking us, why is it that we had 2 positive women, but we only reported 3? And then you say, that will report Makosa. So even at facility level, through our in-charges and the management systems that we have at site, can we look at those MH731s before they are sent forth for data entry into KHIS? Yeah. We need to do periodic data quality assessments within our health facility, of course, with the support of our sub-county management teams. Community PMTCT really for longitudinal mother-infant pair follow-up. We know that if we are not successful in terms of sustaining viral suppression for pregnant breastfeeding women, then we have a risk of transmission going forward. Even when you look at our HIV transmissions right now, majority of our HIV transmissions are happening during the breastfeeding period, mostly because our clans start very well, viral suppression, and then they fall off through the cracks somewhere because they do not have a very robust supportive system to make sure that they stay in care. Our guidelines just recently launched in 2022 have provided for decentralized service delivery systems even for pregnant and breastfeeding women. Are we utilizing those to make sure that we meet the clients at the point of their need? Well, we do know that, yes, the monthly appointment for PMTCT clients, what is recommended at minimum is a monthly appointment. Supposing they are not able to make a monthly appointment, what do you do? Do you allow them to be a missed appointment, or you have a conversation on how you can support them to make sure they regularly stay in care based on the circumstances that they are presenting themselves with? A lot of our clients for PMTCT service delivery are clients who actually work within the informal sector. So if they're working within the informal sector, what that means is that for the day that they are not at the place of work is a day of lost income for them. It's a day of lost income. So if I'm at a place of balance, even for me, if I'm at a place of balance, do I need to go to the clinic or do I need to go to work? I probably prioritize work because work is where I get my source of income for all these other things that I require. So how are we responding to such challenges when our clients are presenting themselves to the health facility? Case management, we cannot overemphasize case management. Is those clients that we consider as high risk for HIV transmission, what are we doing for them in terms of follow-up care? Clients who are high risk, we call high risk PMTCT clients, are clients who are newly diagnosed, clients who have history of falling off treatment. We know our clients who are younger, generally also they have a couple of challenges that they present with in terms of accessing care. Clients who are not virally suppressed, those are clients that are at risk of HIV transmission to their infants, so they need to be prioritized for case management. So this is our infant cascade. I think we'll not dwell on it. You have seen that we have significant gaps in terms of infant prophylaxis, and we have even bigger gaps in terms of PCR within 2 months. And then of course our ANC cascade, even this year as Nairobi, we presented 8,638 women that we have not tested for HIV infection between January and March 2023. So 8,000 women, if we were to multiply that by 4, we will get to about 33,000 by end of year. We don't want to come again next year and do this similar exercise for looking for those women. So let's look at our data for just concluded. We might not be able to change January, March. Actually, January, March we will change because it's part of the RRI period. But we have an opportunity for April to June to look at what we have posted April to June in terms of missed opportunities for HIV testing. And then of course we make those changes. So we have a challenge with case ID for our pediatric population. Yeah, challenge with case ID. So we need to optimize identification of children who are living with HIV. So some of the things that we have prioritized at Nairobi is index testing of our biological children. I want to believe that not all facilities have tested 100% of the children of their index clients. So that's a low-hanging fruit. As much as we are trying to look for these other children wherever they are at, where are the ones that our clients are their own, the biological children of our clients, how many of those have we offered a HIV test? And if they are on ARVs, we have provided antiretrovirals. Yeah. So based on our HAY audit analysis, so these are children who are HIV positive, and then we go out and look at what could have been a possible cause of HIV transmission. Late ANC initiation, number 1. So they will come for ANC, yes, but they'll not come within the first trimester. That's what we are saying. They come, but they don't come within the first trimester. Remember, even if they come at second or late third trimester, you already lost an opportunity for viral suppression by the time they are going into delivery and by the time they are breastfeeding. So the earlier a client comes for ANC services, the better in terms of outcomes going forward for prevention of transmission. So this is an issue of demand, yeah? An issue of demand for clients to present themselves early. Actually contributes to 50% of all HIV transmissions in Kenya and in Nairobi. 50% of all HIV. So it's something we need to look at very closely, and we put in our systems to prevent loss during care. And then of course we have a late ART initiation for our moms. Late ART initiation, as what I have said. So of course we will have activities for engagement of the communities, and for you, a community for you, if you're a health facility, a community for you is not this county community engagement that we are talking about that will be done at that level. A community for us at health facility level is your stakeholders, which are your community members, yeah? Your stakeholders are your community members, the people who are accessing services at your health facility. Those are your stakeholders. So how well are we working with our community health strategy within that community unit to be able to create demand for PMTCT services? Yeah, so demand at various levels. We have demand at level 1, we have demand within the health facility, and then of course we have higher level demand that will be other sub-county stakeholders in terms of PMTCT services. So I don't want to dwell on the slide for stockhouse. We know that we have had challenges with stockhouse right now. We are waiting for the testing labs to provide for us EID results. So we have slightly longer turnaround time that we anticipate than what we anticipate for EID, but we have had a relatively stable environment for RTKs. So those missed opportunities that we presented for RTKs up there, we shouldn't. Those missed opportunities that we presented for ART, actually we shouldn't, because I don't think we have lack of commodities in Nairobi. We have all the commodities for ARVs for moms. We have all the commodities for prevention of transmission for children. So I would like to just end there with the note that really we cannot continue to diagnose HIV infection in children in a county like ours that is very progressive. Yeah, we say Nairobi, we are the pace setters. We are actually the city, you know, that has, and even when you look at some of the resources that we have within Nairobi, probably other counties don't have as much resources as we do. We have over 7,000 community health promoters that are supported by our county government, even as we speak right now. That is a resource that we can be able to utilize, especially for demand and advocacy, and even referral of health services. So how are we utilizing the health services that we have? We have, I think, many health facilities in Nairobi. Of course, we have pockets and pockets of sites that probably are not providing PMTCT services, but we have significant facilities that provide all the services, and they have capacity to provide all the services. If we build capacity of our healthcare workers and we support them through monitoring of our pregnant and breastfeeding women and monitoring of our children who are living with HIV. We have many numbers of clients who are enrolled in our facilities that we have not tested their children. So this is a call to action going forward during this RRI and going forward for us to sustain service delivery really, so that we can end pediatric HIV in Kenya, HIV infection in Kenya by 2027, or if better still, if we can say 2026 for Nairobi, because we have everything that it takes, then that is what we need to do. So we cannot be comfortable. We cannot be comfortable. We need to do things differently, and we need to take care of every individual client to make sure that we give the best in terms of the care that they require for themselves to be healthy, and secondly, for them not to transmit HIV infection to their children, and also to make sure that their children are virally suppressed and they continue to thrive as children of this country, as we would like to see for any other child that is not living with HIV infection. Thanks very much, everyone, for listening, and back to you, please.
Thank you, Lulu, for that well done presentation. It's been an eye-opener for all of us. I want to invite my colleague Kiambi, who will take us through the Q&A session quickly so that we go to the next presentation, which will cover the cryptococcosis in HIV. So welcome, Pia, will take us through the Q&A session.
Thank you, Lulu, for that lovely presentation. I will welcome our online participant and the physical. If you have any question, please ask them to ask those questions. Anyone? From online to the physical?
Maybe I can make a comment or two. Maybe Lulu, we missed to talk about Kajiado, which falls under our region, and of course it's supported by Fahari Jamii. Probably you would like to share the situation in Kajiado as far as the RRI. Is it part of the counties that are undertaking the RRI?
Yes, Chris, and thanks very much. Yes, Kajiado is part of the counties that are participating in the RRI. They have already done a similar exercise like this one in their own county. So probably hence the reason why we probably didn't focus so much on their performance. They've already done their sub-county, their county sensitization and their own cause in terms of putting in the work that is required at health facility in regards to moving this agenda forward. Yeah.
Thank you. The other observation that I've made is still lagging behind when it comes to the technology. We still have very many facilities that are non-EMR. I know for Nairobi we are doing quite well. We are not badly off, but I've seen the map that you have shared. From the country, we are not doing so well when it comes to the technology for electronic medical records. Then I've also noted that from January to March, we have confirmed 23 children to be HIV positive. That's a very huge number. Considering last year, the whole of last year we had 78. If we continue that trajectory, we will go beyond even what we how we performed last year. We'll do very poorly in terms of prevention of or elimination of mother-to-child transmission. So I don't know if all of us are ready to undertake this RRI so that it can help us avert some of these unfortunate incidences where we get in 21st century, 40 years after the HIV epidemic was started in 1980s, we still having children who are seroconverting. Well, we have science supporting that the PMCCT intervention works. So we need to put our heads together to make sure that this 23 remains the 23 so that we don't add to this number, because it's a very unfortunate picture for Nairobi as a county. We are the capital, we should be leading. We are the face of Kenya, so we should be leading in all aspects, starting with even the EMTCT. So back to you, Amos, to continue with the other.
Thank you for responding to those questions. Any other with a burning question?
There's a question.
There was a question here for some. Alice, I think, had asked who is responsible for distributing and ensuring that the MOH 731 is filled. So let me take that and respond. So we have the MOH 731, our sub-county health records information officers together with our sub-county teams. So that scope of responsibility falls with them in terms of making sure that we all have access to the MOH 731 and that we are all filling that MOH 731. If we have pockets and pockets of facilities that probably do not have, or maybe have challenges with access, kindly just reach out to our sub-county health management teams so that we can all be on the same page in terms of that support. Thanks.
Thanks, Lulu.
Back to you.
Thank you. I'd like to invite Kip, Dr. Kip, please. I can see you in the online. And if you have a question, please, Kip, you can ask or make a comment from what Lulu has presented. Kip? This is our Casco. I think this is not online. You can't hear us. I think you can go straight to our next presentation. There's no.
Before we go to the next presentation, thank you, Lulu, for the presentation. Just one question. You've shared with us that there'll be a separate learning session for the tools that we use for this RRI. Is there a tentative date that we can look forward to as we sensitize our team to this? Thank you.
Yeah. So thanks. I want to leave that a bit for Kiplagat. I know Kiplagat has some kind of a tentative dates for when we will be doing all these sensitizations, and I'm sure he'll share. He was not able to come off mute, but let's park that for him. Probably before he closes this meeting, he'll be able to give us some tentative dates. Yeah.
Thank you. Any other?
So let's invite our colleague, Dr. Nzomo, to take us through a presentation on cryptococcosis. Of course, the exercise is ongoing. We'll keep updating all of us on what is happening. I know we have different sub-county WhatsApp groups, and I see a lot of discussion going on in those groups. We'll keep informing each other on what is going on as far as this RRI is concerned. I want to share the presentation for the management of cryptococcosis so that we take the shortest time possible. So I'll invite Dr. Maybe you can sit here so that you can sit down there. Welcome, Doctor. Thank you. Thank you very much, Chris, for this opportunity. And thank you to everyone who's been able to join today. So we'll be looking at cryptococcosis in HIV. It's going to be basically a refresher presentation. Last year in October, we had the same session. We were taken through by Dr. Maduti, one of our senior consultants in terms of HIV care in Kenya. So this is going to be the presentation outline. In case I'm going too quickly, feel free to raise your hand and alert me for both the participants in-house and also the ones joining us virtually. So this is going to be the outline. We look at the background of cryptococcosis, the epidemiology of the thing. We look at the presentation, the differential diagnosis that we encounter when we're looking at cryptococcosis, and the workup for our clients. Then finally, we look at treatment and medication with a few special considerations. So when we look at the epidemiology, so the causative agent is a fungus, that's Cryptococcus neoformans. And occasionally we get infection with Cryptococcus gatti. But most commonly with gatti, it's for the immunocompetent population. And in HIV care, we usually deal with the immunocompetent. So it's primarily transmitted via the respiratory routes, but it's not directly from human to human. We usually get it from droppings from birds and some vegetation. And in terms of the deaths, we have 600,000 deaths associated with cryptococcal pneumonitis per year worldwide. So it's quite significant when we're looking at the causes of death for our population. And in sub-Saharan Africa, 15 to 30% of all patients with AIDS develop cryptococcal disease at one point in their course of management. So the burden for us from this data is quite significant. And in terms of the presentation, most cases are seen in patients who have a CD4 count of less than 200 cells. And from experience, these are clients who are usually newly diagnosed to care with a CD4 of less than 200, or clients who are returning after default. with deterioration in their immunity. So when you look at presentation, cryptococcosis, the presentation is quite varied. Most commonly, we see the CNS manifestations, which include meningitis, meningoencephalitis, and marked lesions. For the marked lesions, more so with Cryptococcus gattii, not so much with Cryptococcus neoformans. So the main presentation that we deal with is subacute meningitis or meningoencephalitis, where we have fever, malaise, and headache as the presenting symptoms. You can have neck stiffness, photophobia, or other classic meningeal signs and symptoms in 25 to 35% of the cases. These include the positive kind. Lethargy, altered mental status, or personality changes are less common, but we can see this in cryptococcal meningitis involving the CNS. The other not so common presentation is pulmonary cryptococcosis, and the signs are fever, cough, dyspnea, headache, weight loss, and less commonly we can have pleuritic pain, hemoptysis, rales or abdominal rub, or in severe cases can present with acute respiratory distress syndrome. And looking at these symptoms, this is commonly what we see in cases of TB and also in cases of histoplasmosis. Some of the additional disease forms that we could see include ocular lesions, where we have optic neuritis, chororetinitis, endophthalmitis. We can have skin lesions, where we have papules, vesicles, can have villi or cancers, and in organ transplant recipients, you can get cellulitis. The other involvements include bone and other organs, including the prostate in males. When you look at the differential from the symptoms that we have elicited, toxoplasmosis is one of the differentials that we could be dealing with. Bacterial meningitis, histoplasmosis, or tuberculosis. That is either pulmonary or tuberculous meningitis. And as we look at bacterial meningitis can occur in isolation or as a concomitant infection when you have toxoplasmosis. When you have cryptococcal meningitis. So the next thing we look at is going to be the workup. So from the lab, we get cryptococcal antigen positive in serum or in CSF. And the bronchoalveolar lavage fluid can have positive CRAG for cases of for cryptococcal pneumonia. And it's important to note that if you have false negative results, does not necessarily exclude cryptococcal infection. And the other form of identification is through the India ink stain, but notably this has a lower sensitivity. So in the absence of a CSF CRAG, it's recommended that you do an India ink. But with a negative Indian ink stain, sometimes it's indicated that we treat for cryptococcal infection based off of clinical suspicion. You can do a culture of blood or CSF where you include the cryptococcal antigen. And for patients who have a positive serum CRAG, which is the algorithm that we use currently, a CSF evaluation should be done to exclude CNS disease before we proceed to treatment. The findings in CSF, we have a mildly elevated protein. You can have a normal or a low glucose, and pleocytosis are mostly lymphocytes, and you can have the yeast on a gram or India ink stain. You can visualize the yeast. We'll see how the yeast looks on an Indian ink stain. The other finding on CSF evaluation is an elevated opening pressure of more than 25 centimeters of water in roughly over half the percentage of people who get infected. So from this image here, we can see how the fungus looks on an Indian ink preparation. Some of the yeast in this image are budding. So this is what you would see from the lab side. The other form of investigation we do is imaging. Quite important, before you do a CSF, before you do a lumbar puncture, it's important to exclude a mass lesion and also a mass lesion which would result in herniation if you were to do a CSF, a lumbar puncture. So a CT is usually indicated prior to lumbar puncture and CSF acquisition. In this image here, we see a cryptococcoma, this lesion right here. So in cases of a cryptococcal infection, especially in the immunocompetent, you can have a mass lesion of cryptococcoma present, especially with Cryptococcus gattii. And important to differentiate the same from toxoplasmosis. In cryptococcomas, most cases they are isolated. In toxoplasmosis, you see the same, but multiple lesions in the CT scan. So moving on, we look at the treatment. So treatment consists of 3 phases. We have the induction phase, which is at least 2 weeks which comprises 2 weeks plus clinical improvements. Very important, the clinical improvement bit. Sometimes the induction phase might need to be extended in the absence of clinical improvement. Then we have the consolidation phase, which is 8 weeks. In some guidelines, the recommendation is until CSF cultures are sterile, but in our setting, with the lack of access to cultures, clinical improvement is most of what we look at. And then maintenance therapy, previously used to be lifelong, but in current practice, once we have immune reconstitution on ART, that is a CD4 more than 200, in 2 6-month apart measurements, we are in a position to stop the maintenance therapy. So now looking at the treatment regimens, the preferred treatment regimen in our current setting is amphotericin B, the deoxycholate form, at 1 milligram per kg, in addition with flucytosine 25 milligrams per kg, 4 times a day for 2 weeks. This is in conjunction with therapeutic lumbar punctures where indicated. I will be able to see the indications for the lumbar punctures, appropriate hydration, taking into account the effect of amphotericin B on our kidneys, and also renal monitoring with magnesium supplementation and potassium supplementation. The consolidation phase is 8 weeks of fluconazole at 800 milligrams per day. For children and adolescents, this is 6 to 12 milligrams per kg per day, up to a maximum of 800 milligrams daily. And the maintenance phase, that's the secondary prophylaxis, we use fluconazole at 200 milligrams per day, or 6 milligrams per kg per day for adolescents and children for at least a year, and until the CD4 cell count is more than 200 for 2 measurements, 6 months apart, and our viral load is undetectable. It's indicated that if our CD4, after this initial phase, if our CD4 goes below 100 cells per millimeter, we might be, it's recommended that we are in a position to reintroduce our prophylactic fluconazole. The alternative treatment is amphotericin B at 1 milligram per kg per day, in conjunction with fluconazole at 1200 milligrams per day for 2 weeks. And for children, the dose of fluconazole is at 12 milligrams per day. The therapeutic lumbar punctures on alternate days, appropriate hydration, renal monitoring, and magnesium supplementation on top of potassium. The consolidation phase remains the same, and maintenance and secondary prophylactic phase remain the same for the alternate regimen. So this slide has been derived from our guidelines, the 2022 HIV prevention and treatment guidelines. So basically, this is a repetition of the previous 2 slides that we've seen. So the preferred is our AmphoB with flucytosine, and then in our current setting, in the absence of flucytosine, we can use fluconazole. And quite important, we defer ART until completion of 5 weeks of cryptococcal meningitis treatment, and we have clinical resolution of the symptoms. The purpose of this is to avert IRIS, which is quite common in clients who have initiated treatment for cryptococcal meningitis. So just to refresh our memory, this is the flowchart as is in our current guidelines. So for newly diagnosed HIV infected adults or adolescents, the initial part of the initial workup we do is a CD4. If our CD4 is less than 200 cells per minute, per millimeter cube, we do a reflex CRAG. And also the CRAG is indicated for clients who are symptomatic, even if their CD4s are above 200 cells per millimeter cube. If our client is CRAG positive, we do a symptom screen, and then based off of the symptom screen, we do a lumbar puncture. If they're asymptomatic, we can offer presumptive treatment for possible cryptococcal meningitis. And the dose, when we're looking at presumptive treatment, is fluconazole at 1600 milligrams per day. That's high dose for 2 weeks, followed by 800 milligrams per day for 8 weeks, and then 200 milligrams a day for a year until the CD4 count is greater than 200 for 2 measures 6 months apart, and we have an undetectable viral. In all instances of a positive CRAG, symptomatic or asymptomatic, we are defining ART for the minimum of 5 weeks, also guided by our clinical resolution symptoms. more so around treatment and medication. So elevated intracranial pressure is associated with cerebral edema, clinical deterioration, and a higher risk of death. Therefore, therapeutic lumbar punctures are a critical component of the management of cryptococcal meningitis.
Management, and we have tools as well.
We can hear someone from the participants, probably a question or a comment. We can't hear you quite clearly. Okay, we'll proceed and then probably we'll get to hear more in the comments and questioning section. So we're looking at treatment and medication. So the indication for therapeutic lumbar puncture. So initially at opening, at diagnosis, if you have a CSF pressure of more than 25, it's indicated that you do a therapeutic tap at the same time, drawing off about 20 to 30 mils of CSF at that point. And as continued daily therapeutic lumbar puncture, if the opening pressure on the day is more than 40, we draw off enough. Is less than 40 but higher than 25, we draw off enough to reduce the pressure to under 20 centimeters of water. And if the opening pressure is more than 40, we draw off enough CSF to reduce the pressure by 50%, and you continue the daily LPs until the pressure is normal for 3 consecutive days. The risk with a higher pressure of more than 40 is if you draw too much, that's taking it down to under 20, we run the risk of herniation, brainstem herniation. And following this initial phase of treatment, once we've gotten the pressures normal for 3 consecutive days, repeat LPs are guided by the persistence or recurrence of signs of raised intracranial pressure. And at each setting, we usually draw about 10 to between 10 and 30, guided by the pressures that we have at that point. So this image basically shows the first one, image A, is an improvised manometer for CSF pressure calibration. So it's a giving set attached to the spinal needle, and you use a measuring tape for the same. So there's this improvised version, and on the right, we can see now the standard CSF manometer, which is calibrated. In most cases, we find ourselves using the improvised one, but if you do have the calibrated one, standard one, quite in order. And going more so, looking at the amphotericin B therapy, one of the biggest hindrances to treatment is the toxicity, the renal toxicity of the same. So for adults, how we manage this or prophylaxis, preventative treatment of the same, you give a liter of normal saline with 20 milliliters of potassium chloride 2 to 4 hours before each controlled infusion of AMPO-B is given, and the AMPO-B is usually given with a liter of 5% dextrose. This averts the dehydration, averts acute kidney injury secondary to AMPO-B, and also the potassium replacement, the secondary hypokalemia that we see. And going forward, you also add 2 tablets of 8 milliequivalents of potassium chloride orally twice daily, and an additional 8 milliequivalents of HCl may be added in the second week. So the other thing is including magnesium supplementation at 250 milligrams, tablets of magnesium trisilicate twice daily, or 4 milliequivalent tablets of magnesium chloride twice daily. This information can be gotten within the guidelines. For adolescents and children, similarly, we give a liter of normal saline with 20 millimoles of KCl over 2 to 4 hours before each controlled infusion of AMPO-B. Monitoring the potassium, we obtain twice weekly potassium and creatinine. So if the potassium is less than 3.3, we administer a liter of saline with KCl 40 millimoles of saline, or 1 to 2 tablets of 8 milliequivalents of KCl every 8 hours. And you add magnesium as you're monitoring the potassium in cases of hypokalemia. If the creatinine level increases more than 2-fold from the baseline, we stop administration of amphoB and increase hydration to 1 liter every 8 hours. When we stop the amphoB, we go up on the dose of our fluconazole to high dose fluconazole. And as we're monitoring the renal function, if there's improvement, you restart amphoB at a lower dose, that's ideally at 0.7 milligrams per kg on alternate days as you continue to monitor your creatinine. If there's no improvement as you're monitoring your creatinine, that's what you were saying, you give the fluconazole at 1600 milligrams. That's the high dose to complete your induction phase of therapy. So essentially, that's what we're looking at in terms of management. Other than the deoxycholate amphotericin B we have in place, we also have the liposomal amphotericin B. And as we're looking at pregnancy, the diagnosis of crypto in pregnancy is similar to that for individuals who are not pregnant, and treatment similar to what we're looking at for the non-pregnant population should be initiated promptly after a diagnosis is confirmed. One thing we need to look at is antifungal therapy during the postpartum period has been associated with an increased risk of IDs. So we should have a high clinical index of suspicion as we're dealing with pregnant women in the postpartum period. So the recommended treatment for pregnancy is the lipid formulation. That's the liposomal amphoB. Doses are usually around 3 to 4 milligrams per kg. And it's prepared as the initial regimen for treatment of crypto in the induction phase and in the maintenance phase with weekly doses of the same. Fluconazole has been associated with teratogenicity. Fluconazole has been associated with teratogenicity together with flucytosine. So in the initial, flucytosine should only be considered when the benefits outweigh the risks to the fetus and only in the 3rd trimester. For fluconazole, similarly, in terms of maintenance, once we've gone beyond the 1st trimester of treatment, fluconazole can be used in pregnancy, but it's been noted that in terms of risk to the pregnancy, because abortions are what you usually see when use of fluconazole in pregnancy is instituted, sometimes severe illness as a result of cryptococcal meningitis or cryptococcosis leads to the same outcome. So in some instances, we find ourselves biting this poison plate. In closing, we're going to look at IRIS. So up to 30% of clients who are initiated on ART as part of their treatment for crypto develop IRIS after initiation. And it's sometimes difficult to distinguish the IRIS from treatment failure, but in terms of management, there's continued ART and antifungal therapy. In some instances, you need to reduce with an amphotericin-based regimen. And as part of management, reduction of intracranial pressures if they're elevated, as you've seen the indications for therapeutic lumbar punctures for these clients. And importantly, we delay ART for 5 weeks from initiation of cryptococcal treatment, and together with clinical resolution or clinical improvement for these clients of ours. This, we're looking at paradoxical IRIS, but in some instances, we also get unmasking of IRIS for clients who we've had a few stockouts over the years. In some instances, we do have stockouts of CD4. So initiation of ART sometimes is preemptive of getting a CRAG or a CD4 that would now necessitate a reflex CRAG. So not only paradoxical IRIS, but also we do have cases of unmasking of IRIS. So quite important to look at, especially for clients who are initiating in the absence of a CD4. So that was it. Hopefully I didn't go a little too fast for the team, but considering we have gone through this presentation last year, for most of us, I'm sure we've gone through this. It's basically a refresher. So at this point, I'll open it up for questions, and maybe you can take us through that session.
I think that pick up the sheets, Doc, for that minute to the Yes, I know we encounter this CA for our land, our facility. I hope this will be very informative to us when we come to the meningitis in our patient that is suffering. So finally, at this point, I invite those with comments Questions, reactions? Thank you, Dr. Zomo. I would like to understand why is there this risk of iris related to treatment postpartum. Yeah, you just presented in the slides that there's this risk of iris in vitro management, even postpartum period. So why is it also like that?
In terms of the rationale, from the research that I have done so far, I didn't get evidence of the rationale as to why the risk of IBC in postpartum, but from the studies that have been done, the risk is much more significant in the postpartum period as opposed to the intrapartum period in fertilization. So the rationale itself, we need to do a little more research on the same, but based off of the studies done, the risk is much higher as opposed to the general. Yes, Kibanda. Yes, Kibanda.
Yeah, just a thoughts on Doc's thing. What are his thoughts on the when you look at the use of deoxycholate form of amphotericin versus liposomal liposomal in the context of cost-benefit analysis? When you think of the monitoring tests that have to be carried out when you're using the deoxycholate type as opposed to liposomal, would it break even? And because looking at the safety profile, at least there's some level of safety when using the liposomal as opposed to the deoxycholate. What would be your comments on in terms of cost? Would it be just prudent to use deoxycholate as opposed to minimizing costs using liposomal, then end up now having additional monitoring that will, of course, will incur cost in terms of the electrolyte imbalance and basically all the renal function?
Thank you, Kibanda, for that question. So looking at the deoxycholate versus the liposomal, one of the drawbacks we have for liposomal is the availability for the liposomal, because in practice, most of what we encounter is the deoxycholate. But looking at the monitoring as well, the liposomal is much more safer for our kidneys as opposed to the deoxycholate form. So in terms of a cost-benefit analysis, I'd say depends on the setting you're in. Could be a zero sum when we look at the cost of acquiring liposomal versus the use of the deoxycholate with monitoring. Because for the deoxycholate, we've seen if you have adequate hydration and adequate replacement preempting, you have less cases of acute kidney injury and the necessity of more frequent renal monitoring, because we do see that for renal monitoring is twice weekly indicated, and the twice weekly renal monitoring is during the first 2 weeks of treatment. That's the induction phase. And after that, for the consolidation, because we are out of alcohol, there's less need for the renal monitoring. So looking at the cost benefits, we're also commonly using the deoxycholate because of availability and also the cost limitations of liposomal. It's a little bit more expensive than the deoxycholate form.
Okay, thanks.
Sorry, I have another question. Why you say that estimated therapy is not in the CMI?
From previous experience, the steroid management, steroidal therapy in medical management or generally in fungal diseases, sometimes can lead to worsening of the fungal infection. That is why, in most cases, of fungal infection, steroid therapy is contraindicated. And another thing I have failed to mention on the tip was to do with our management of increased intracranial pressure. The medical therapy that should be monitored and monitored and hypertonic saline haven't really been shown to be effective when you're dealing with cryptococcal meningitis in the ICP. But for the steroidal therapy, the same, a bit of, when you're dealing with IVs, steroidal therapy is needed. So in CM, IVs, in some instances, case by case, you might need to report to steroidal therapy, but that's on the case by case.
I think I want question, Doc. Mine is what is the interval of doing therapeutic electives?
So the interval of doing therapeutic LPs, in the initial phase, it's usually a daily LP. When you're concurrently monitoring the pressure. So if your pressure is above 25U, I do a daily one until you get your pressure within normal for a period of 3 days. And after that, you can stop your LPs. And the decision to initiate an LP is once you have, if you have clinical consideration and you have signs of ICP, at that point you're indicated to do another therapeutic LP as guided by the symptoms to show that our pressures once you obtain your CSS.
Yeah. Another? Yes,
Thank you very much for a good presentation. My question is, a patient is a brought back, presented with TB signs, but the crab is so positive as a TB.
Crab is positive as well as a TB. So in terms of management, if you have a positive serum crab, we have to do a CSF crab for the same time to exclude that meningeal disease. And since you have a positive TB on smear, it will also be indicated that on the CSF as well, you do a gene expert for the same. So this is a client with a return after default. So we probably need to manage with infection, concurrent yes at the onset. And quite importantly, because return after default, we expect that CP2 is going to be done. In the initial phase, looking at iris, that's going to be one of the major considerations of it. So we need to manage for both the TB as well as the crypto, the crab positive that we have, and also as part of the evaluation, we ensure that if we have CNS involvement or not, we are managing that. For the TB, we do IR or TBM. For crypto, it's also going to change dependent on our CSF countries. Yeah.
Any other? Before you go to our online participants, do you have questions? And this is from Prince Chapo, why the use of corticosteroids are indicated in management of meningitis. This has been asked by one of our physical participants. Chapo, hope you have been answered. This is from John Domo, management in pregnancy. I think you how to manage CM in pregnancy.
Okay, so the last few slides we were looking at CM in pregnancy. So in terms of management, the preferred regimen is the liposomal and amphotericin D. Our other two agents, that's fluconazole and flucytosine, are contraindicated, associated with hepatogenicity and intrauterine fetal death, most commonly within the first trimester of this. So liposomal ampho-B for the first 2 weeks of induction, and following the first 2 weeks of induction, and in our consolidation phase, we can use weekly doses of the same. And then in terms of our maintenance, usually after the first trimester, we can resort now to flucytosine or fluconazole for the clinical presentation and on a case-by-case basis for our pregnant parents.
I might ask, how do you go about when teaching CM, and not feed the patient? What's the fact that this data they're using CM, but they didn't feed the patient?
Okay, in renal failure, most usually we use the high-dose fluconazole variants. That's what we would need to use, considering the fact that amphotericin B clearance in the kidneys and the effect of worsening renal function. And the other thing that we would need to consider when we are using amphotericin B in clients who have pre-existing hyperkalemia or in pre-existing hyperkalemia or none, in some instances of renal disease not necessitating withdrawal therapy, the potassium replacements that we do, we shouldn't ideally replace potassium in a client who has a hyperkalemia or had impairment in their potassium clearance. So for renal failure patients, a high dose fluconazole would be what we would go for in terms of safety.
Thank you for those responses. Yeah, from our physical response. Let me ask questions. I know we're not doing in our faculty. Any other questions? Probably close this presentation. Yes.
So currently we have DBT, TBM, and cryptococcosis infection. So in terms of the DBT therapy for DBT, we have the anticoagulant medication for that clients, as well as monitoring for any risk of EOL, as of when we're using the results of the DBT. For TBM, management should remain the same. That's our average study, the initial 2 months, followed by a 10-month course of average. Crypto, diagnosed cryptococcal meningitis, or we have a positive settlement. The GFI in the course of treatment and stuff. So we're already beyond the induction phase of this time. So currently we're on 2.0. We're in the induction, we're in the consolidation phase of the maintenance. But in terms of maintenance, our 200, we continue with that 200 for the quarters, monitoring our team report as well as the Bible. For TTM, we do this. And quite importantly, when we're dealing with these clients with complicated comorbidities, we have comorbidities in the setting of our treatment. For these clients, it's already important that we go. Senior physicians, those are our consultants, that are nephrologists in the picture. So as we continue the management, we do have the networking.
Thank you. Now we go to Chris. Chris, yes. In the research, because we receiving a client average low less than 254 count without that reflex, the client characters. So I don't know if you are checking for your permission.
So you do a thing before it is below 200, but you are not doing
a study for extra practice.
Let me back. So you evaluate your patient. If your patient seems like they have a meningitis, you would rather put them on components. Because some instances, if you miss to do that, you start that patient on treatment, they will die. So you weigh the risk of treating because cryptococcosis serum crack is around 1,000 per. Yes, around 1,000. So most of our patients are not able to afford. You weigh, if they have the symptoms that are consistent with, you treat empirically. So there is a room for empirical treatment for cryptococcal meningitis. Okay. Yeah. So if there is not any other, there is a question with improvement.
This is from Lucy. With improvement of creatinine levels when using amphotericin on alternate days, for how long will this be?
So if you have improvement in the creatinine levels and you resort to alternate day amphoterapy, the induction phase remains your 2 weeks are guided by clinical resolution. So following your 2 weeks, we get off our amphoterapy and then we now continue with our fluconazole in terms of consolidation as well as secondary prophylaxis. So the induction period will still remain the 2 weeks, guided by our clinical resolution of symptoms.
Okay. Thank you, team, for well done participation. I think because of time, I would request if you can go for tea. Then we do a working tea as we discuss the two places from Matt and Dora too. We can do a working tea. Yes, so for our online participants, we also allow you to take some tea, whatever you want. So that we assume in the next 15 minutes, we discuss the two DRT results. I would request you to hang on, don't leave the meeting completely, because what we will be discussing is very important, especially when it comes to learning on how to do interpretation for the DRT results. So we go for tea, 15 minutes, we'll be back.
Yesterday, that very surprise.
Okay, so we want to do something quickly. So we want to do something quickly on the two DRPs that we have for discussion. But before we dive into the DRT interpretation, good to understand the ART history of these clients. Good. Good. So we want to pick from where we stopped. This is a case from the Doyle Center, the Dora 2. So I don't want us to go through the whole case. This is a case that was reviewed by a technical reviewer or a mentor within the sub-county, and then recommended a TRT just to know that we are dealing with 47-year-old lady, and this is the ART history. So the client was started on AZT, B40, 3TC Nevirapine. That was in 2008. Then something to note. I hope the online participants, you can hear us. We have received anyone from the online participant. We don't want to lose you guys. Yes.
Yes, we can.
Good. So this is the patient who was started on B40, 3TC Nevirapine. That was in 2008. Then you can see there during that time, client was on TB treatment. So something that we note here, there was a mistake that was done. Why? We have Nevirapine and we have TB treatment. They can't go together because of rifampicin, drug interaction between rifampicin and Nevirapine. Then when you look at the CD4, the baseline CD4 was 190. That was in 2008. Then 2009 it was 392. Then it dropped, and this is the time patient developed another relapse of TB. And that is the time we were phasing out B40 because of the issue that B40 had. Something to note is that both B40 and AZT are thymidine analogs. So moving from B40 and to AZT, you maintain the same drug with a similar resistant pattern. Then we continue, we get in 2014, the CD4 dropped to less than 100. Then the first viral load was done in 2015, which was 101,000. Client was still on AZT, 3TC Nevirapine. So you start looking at probably treatment failure started coming along from 2013. Because that is the time we dropped from 392 to 322. Then there was also clinical presentation of TB. So both immunological and clinical manifestation. Then this confirmed our immunological failure, the CD4. So the CD4 of 90 confirmed immunological failure. Then The virological failure was confirmed by the subsequent viral loads. Client was still on the same regimen. The client was on the same regimen of SLT3TC nevirapine. Then the switch was done in 2016. That is 3 years later. Yes, thank you, Kibanda. We have noted your comments on the two presentations. I think we really appreciate them, and thank you for reminding us and reminding them that they did a good job. So in 2017, that is when the decision for switch to second line was done. That is 4 years later. Yes, 4 years later, after the patient had started developing treatment failure. So the client was put on TDF-3TC, a TDR, which was, of course, as per the guidelines. Then we proceeded with the T. This should be the first viral load of the switch. We are not clear. Someone said we are loud and clear, and someone else is saying we are not clear. Are we?
You are very clear. You are very clear, Chris, unless it's the network where that person is, but you are very clear.
Thank you, Kibanda. So, so we have another viral load. So there was no viral load done between 2017 to 2020. Probably we could have picked treatment failure while the client was on second line. There was that we missed that. Then we proceed. So basically, this client never suppressed while on second line. Now, when you look at this, even the CD4 improved. There was some improvement on CD4. Then it went down again to the current, which is 106. When you look at that picture, what do you expect when it comes to mutations? Sasa leo mko hapa physically hakuna kuweka maswali. What do you expect in that picture? So the client was on the amandine analog failing for 4 years. We expect terms, probably 1, 2, 3 terms. What will the terms do to our TDF? It will reduce the susceptibility of TDF. So probably by the time we were putting this client on TDF-based regimen, TDF was already not working fully. So probably the only molecule that was fully active was ATBR. Now that brings a lot of pressure on ATBR. And by this point, probably there is some level of PI mutation. That is how you analyze the case based on the ART history. I don't want us to dwell much into that because it's something that we will do in the coming months when we start getting the DRT result. I want to stop so that we can go to the DRT result directly. So this is the DRT results. So let me share. So this is the DRT results. So by the time we were collecting, I want to increase the font. So by the time, are you able to see from those who are yes. Now by the time we collected the sample, the viral load was 23,132. So we are at least convinced that this client was taking medication by the time we were collecting the sample. If the viral load was maybe 200,000, that's a lot a client was taking medication. Then you will allow me to scroll very fast because there is some information I don't want you to see about the patient. We have covered this very well. We have also covered the CD4, and this is a well done DRT result. Because with this, even without the summary, you will be able to make a decision. So let's go to the DRT results. So we start with the proteins, the PIs. So you can see we have M46I, and M46I is a very bad PI mutation. I will tell you why it is a very bad. Actually, not M46, but I84V. You see, and I will keep reminding you this. This client has only been exposed to Atazanabia. But look at what is happening to the others. Why do you think we have this picture here? Client was only exposed to Atazanabia, but we have that picture for PIs. And someone? Resistance, what type of resistance is that? Close resistance, yeah. So there is close resistance between the class. So because we put a lot of pressure on ATBR, client developed I-84B, which reduced the susceptibility of ATBR. It went ahead and reduced the susceptibility of NPVR, and our most effective ARV that we have in the country is Darunavir, also was affected. And I want to show you why this mutation is bad. Let's look at it. Someone want to speak from the online participants? Now let's look at the major PI mutation, that is I-84B. So the I-84B is a subscript cleft mutation selected by each of the PIs. It reduces susceptibility to not only NPVR but also ATBR and Darunavir. So it's what we call when I call it multi-drug, because it is the moment you confer that, it goes with three PIs at once. So that is what happened to these clients. And most of these mutations are caused by delay in intervention. So if we did that, maybe if we made a decision in 2017, the PIs could be all susceptible. But because we delayed it, because remember we did do any viral loss between 2017 and 2021. That was a big delay in the viral load. Let's go to NRTIs. Here we go. Now we talked about the possibility of terms. And this one is confirmed by, we have D67N, this is the term. K70R is a term. K29Q is also a term. And T215 is also a term. So you can see, basically we have 1, 2, 3, 4 terms. I want to confirm, yeah, these. So we have four terms. So anytime you have more than 2 terms, you'll have HNT. Problems with HNT. So HNT will be high level resistance. And it will not stop there, it will also affect the ABC and TDF, which is different from K65R. Why is it different? Why is K65R different from the terms? If you are K65R, you are not even worried. It's not good, but you're not worried as much as when you have terms. You're learning, yeah? Someone? And I think you want to try it. Or someone from the online participant, you can unmute and speak. Why do we get worried when we see the terms, but not as much as when there is presence of K65R? I know Kibanda knows that.
Hey, Chris. So normally you find that that mutation is really selected by TDF or Bacavia and the older thymidine analogs.
Okay, thank you, Kibanda. So basically, we said the presence of terms will not only go with the thymidine analogs, that is SNT and default. So collaborate. Yeah, so we have it will not only go with, it will not knock out, it will not only knock out the thymidine analog, that is SNT and D40, but it will also knock out the TDF and abacavir. Now, A65 on the other hand, A65R will knock out ABC and TDF, but it will improve the AZT. So when you give AZT after A65R, you are giving a more improved AZT. That is why I said we are not more worried, and that is why we always start with TDF. We recommend starting with TDF instead of AZT. There is another animal, M184. You see, I skipped. I said D67, A70, I skipped this. What is this? What about this? It's a very M184V mutation. Why is it a very important mutation? It's confirmed to 3TC and FTC. It increases the susceptibility to TDF and AZT. That is number one. Number two, it reduces susceptibility to what? To ABC and 3TC and FTC. So you number three. Very important, number three. The presence of M184B causes production of poorly replicating virus. So in presence of M184, the virus that will be produced will be unfit or will be poorly replicating. So that is why we don't, even in first line, second line, third line, whatever line, you will always write 3TC or FTC because of that advantage of M184B mutation. But avoid giving APC with 3TC, especially on a patient who has developed M184B mutation, because the presence of M184 will keep reducing the efficacy of ABC. And that is why ABC, we only give to children until they reach that, then we transition them to TDF. So that is the reason, because we are not able to give TDF to children below that kgs. We give ABC, then we pray that they will not develop M184B. Then obviously 30 kgs to transition to TDF. The good thing with ABC, if they develop a mutation because of ABC, they will be A65R. Remember when they released another study, there was an evidence that you can recycle TDF even when it has a K65R mutation. So I want us to, I don't want to talk about this, the NNRTIs, because of the risk of what? The risk of archival mutations there. Because this slide has not been on NNRTIs for how many years? From 2017. And you have a second line 2015. 2017. So from 2017 up to today, there is a risk of archival mutation. But due to presence of K103, there is high level to nevirapine and there is high level to efavirenz. Good. So let's formulate arrangement for this client. Maybe a point to note is that this client has never been exposed to DTG. So we have DTG as one of the options. So let's start with the PIs. Which PI will we pick? So we'll pick darunavir. Okay, so I wish to have one in there. So we have okay, let's do this. Because to measure the mutations and the interpretation of the mutations, someone to give us the old regimen so that we get like three, we critic the three. So we have healthy darunavir. Someone else? See, you want to try it? We go for the same. So let's get another one. Let me put TLD.
Yes.
Let me use TLD. Any other Can we use SLT? Can't use SLT because it's already high level resistance. And there is no evidence of recycling SLT. Yes. So we have these two. We have TLD plus darunavir. What is the, let's start with TLD before when we introduce darunavir. So we know DTG will be fully active if this client does not acquire a resistant int mutation. That is the transmitted int mutation because you can get a transmitted one. So the assumption is there is no transmitted int mutation, so DTG will be fully active. Then TDF is low level resistance. If we give TDF, which is low level resistance, the DTC we have no problem with it because of M184V. Will we achieve viral suppression? The answer is yes. Yeah. But for how long? Because we will be putting a lot of pressure on DTG. And the idea is to have at least 2 active molecules when you are formulating a residue. So because of that, because if we put this client on TLD, 2 years down the line, we'll have a INST mutation. So DTG will also go. So we give it another support. We give darunavir. But because darunavir is already compromised, we'll give it twice daily, not OD. So this client will get TLD plus darunavir. Of course, NPIs will give with darunavir. That's a question I like asking. Why do we give PIs with ritonavir? Ama mnapeananga tu unasema ni patient as when niulize hiyo swali. Why do we give? Why do we give all the PIs with ritonavir? Almost all, except the big one, which we don't. Someone is a booster. So someone has told us it's a booster. I think the only it's about the half-life. Yeah, tell us more about half-life. Yes, it is about half-life. It prolongs the half-life. So basically, ritonavir is what we call pharmacokinetic.
Okay.
Yes, Kibanda.
Sorry, I was just mentioning the issue of pharmacokinetics. That it at least it creates a stable environment because for the LPVR and the lopinavir, tazonavir. So like tonavir creates an inducive environment, and it affects the bioavailability through more or less mediating through the pharmacokinetics.
Thank you, Kibana. So that is exactly what I wanted to say, that ritonavir is a pharmacokinetic enhancer. So what the property that it has that is very important, it inhibits the cytochrome P450, and especially what the cytochrome P450 isoenzyme that is specifically to the PIs. It's called CY3A4, I think, that one. So that one, it will inhibit. So PIs are metabolized by that isoenzyme of cytochrome P450. So when you inhibit, you will slow down the metabolism. So the metabolism will be slowed. So there will be increased half-life. So come on now, if I share after 12 hours, it will extend for some more hours. So basically, in the long run, there is improved bioavailability. I want us to, unless there is a question or a critique on the decision that we have made, we can go to the next case. Anyone with a different opinion? Good. So we can proceed to the next case. That is from Mata Hospital. So we have noted that the delay in making intervention has made us use our only remaining PI. So in case of there is an appearance for this client, and actually this is not a typical guideline. This is a salvage treatment because we don't have two active molecules. So if this client is not adherent to the treatment,
That's an intervention.
yes.
This scenario, we don't need to stop at that because we now have to look at ourselves.
Yeah.
Because we are directly responsible for this. Most likely, we are directly responsible for this state of affairs, this patient.
Absolutely.
You realize that this patient, having been initiated on ART in the year 2008 until 2014, that is when the first viral was done. 2014. Yeah. And also, I also noticed another omission here. In the crime of, in the TB of 90, there is no indication of whether it was done.
Yeah.
So it actually comes down to us, the healthcare practitioners. Our missions or omissions largely contribute to the situation that provide our patients in, and we can do better.
Exactly. So I was trying to avoid that discussion because that case was given to a reviewer who did that review and recommended all that. But for learning purposes, those points are very valid. Look at this. This was done in January, and we don't have. Yes.
Maybe up one is the results for the card.
But you are advised to put the result here. I understand, eh? I understand that because if you give me this, you see, I will judge you differently, but it's okay. I know someone has done all that, and there's a lot of history that we didn't go through here, of course, which will answer most of our questions. I wanted us to save on time because there is someone else who is working on that case, and that is why we devote that function to the sub-county so that we don't delay the intervention, so that the interventions are done within the sub-county. But in case of such a case that require experts, require some experienced clinician, they are brought to this forum. Makes sense, eh? So that we shorten the delay in intervention. Good. So let me go to the matter case very quickly. Matter case is so at the end of this, we will write a very good paper. You have given us a lot of literature, and especially on the delay of intervention. We write a very nice paper to showcase that those who are doing interventions correctly, the patient are having better outcome compared to, and especially when it comes to mutations. So let me go through this. This is the patient from. I was told not to call our clients patients, but to call them recipient of care. Yeah. So this is a recipient of care from Mother Hospital. I was diagnosed in 2011 during pregnancy. I don't want to go through this history because of time, and I know someone has done this already. So initiated on TLE, that was the CD4 was 248. Then the HB was 8. Probably this HB was the reason why the client was put on TLE. When in 2011, the preferred first line was the AFIA. Here the sharp there. Then you look at the reports that were done by Mother team until 2014. The client was improving. Then in 2013, the CD4 started going down, and in 2014, they went even down further. And this one we can comfortably diagnose immunological failure. How do we define immunological failure, by the way? when unafanya NHITC. If you lose the 3/4 of the highest. So the highest for this client was 618. So 618 is more than 210 is 210 is you have lost like 2 bags. The other definition is below 200. The ingine ya mwisho na kwanga ine. Milioni of failure. Watatu. NHITC. So we have also those who are not the CD is not picking. So my answer client that about CD for 100 1 year 6 months data or 102 103 yani. So that is also neurological failure. Then we have the biological failure, which is obvious. So by this 2014, this patient and the recipient of care, I must get used to recipient of care. So the recipient of care and developed immunological failure. This was confirmed by the virological failure going forward. So this slide never suppressed until now. You see the delay that happened between 2014 to 2017. How many years are those? 3 years, 3 good years. And that is the time we made a decision to put this client on second line. You can even see the weight has dropped from the highest of 85 to 63. So there is a lot that was happening, including the clinical failure. I feel like this patient probably under TB or something, some Y's around this area. Then you can see client never suppressed on second line. And then we have a cryptococcosis meningitis that was treated in 2020. Still, there is delay of interventions for mother team. And this is not only happening in mother and the DORA 2. All the cases that we discuss here, they are female. We have a lot of delay in interventions. And we noted that one of the reasons why there was delay is because people were not comfortable to do case summaries because we were bringing them to this panel. And that is why we said, no, we will not bring people to this panel. Let's move this discussion to the sub-county so that you discuss with the people you're used to. Yeah? Usipatane na professor hapa kupeleka mbio. We want you to discuss with your peers within the sub-county so that in case there is anything that requires professor, maybe intervention, we can do that for you. We can forward the case to the specialists directly. So that now we reduce that upper. Because we noted there was a lot of upper there. When it became, yes, you know this client will benefit from summarizing and taking the risk, but because when we brought today's panel and people will ask you a lot of questions, then we had to make a decision to involve that function to the sub-county, and it has worked. That is why we have started getting these decisions made. So you look at it. So this client I'm told was diagnosed diabetic in January, June. So we also have diabetes as we did the regimen. So let's go to the DRT results because of I only have 3 minutes to make a decision because there's another team that is supposed to come to this on. What is it? So this is it. And this is for Metadora. So this is for matter. Let me scroll down. I don't want you to see which my recipient of care name. Might be your relative. Wonderful. So let me increase the fonts. So we want to start with the PIs. Actually, we have not discussed what we expect. This client was failing TBI for a very long time, for 4 years. What do we expect? Let's start with the NRTI. what are sure will be there? There's one thing one mutation that we are sure doesn't given you are not sure. M1 ikitoa hiyo lazima itakuwa sio? Kama itakuwa hapo narudisha hii sample kwa ngine. We are sure it will be there. Gani ingine? Case paper, there is a possibility it is there. So PDF tends to have higher genetic value to the system compared to other NRTIs, but we will see. What about the terms? Do you expect terms?
Yes.
Maybe the question is, can K65R, can a client develop K65R together with terms? So the answer is no. You cannot have both. They are, we call them, there is a word that we use, they can't happen together. But I will get that term for you. They can't happen together. But in some instances, let's just go through this. So this is the picture of, so this recipient of K is on TDF. No, isn't it? It is ATBR. So you can see ATBR. And you can see the LPBR. So the ATBR is high level resistance. But we have the Nunavia, which is acceptable. And whatever saved this client is because he has not developed I-84B. You remember that one? The I-84B, the one that we mentioned in the previous case, which is more multi-drug resistant. Causes the presence of it causes cross resistant to our three main ERs. Then we go to this. So we are told there is no even K65R. What we have is terms. We say the two cannot happen together. I remember if anyone from the online participant knows the term that we use for the two. So you can see we don't have K65R, but we have terms. So in case we end K65R, these clients are going to develop terms. I will show you right away from the literature that they have some. So we have this is term number 1, term number 2, term number 3, term number 4, term number 5. So within a very short time from 2017 to 2023, this client has developed these 4 terms. And that is what has caused the problem with this one, this TDL. So basically there is no NRTI to click from, except of course the DTC, which is because of M184B mutation. I don't want to talk about the nucleosides. That is why I told you TDF seems to have, when you look at the literature, TDF has higher genetic value. You see, this client was on TDF training for over almost 4 years, but they didn't develop cases prepared until when we put them, the client on AZT, and we have developed at least 4 times within a period of how many years? From 6 years. Yes. Of course, this also goes down to the delay in intervention. The other thing is, this client has never been exposed to DTG. Now, let's come up with the regimen. Let me tell you the term that case is very bad. Anyone with yes, this is the term I was looking for. So K65R rarely occurs in combination with terms because K65R at most terms, not all terms, exhibit bidirectional antagonism. That is the term, bidirectional antagonism. So when you see one, you won't find the other one. As it began, you can acquire now. As in New Good. Now let's get the regimen for this client. This we know we have the number, we have ATG. So we want to come up with the backbone. Someone? So what will we give? Maybe hapa anangoja kusikia anaenda na nini nyumbani. The news yenye anapelekea mtoto wake ni gani? Then a baby boy or a baby girl? Huh? So don't you want to try? What I would give but because of the regimen formulation you have, we just go for probably TL. So we have 3TC, TTG, darunavir. Then we have TLD plus darunavir. Okay, so 3TC, TTG, darunavir, perfect. Because we want to tap on the M184B, then we'll have two molecules that are fully active. But now, getting this formulation means we'll get 3TC kando, hata inapatikana kweli. Haya utabidi utafute 3TC kando na darunavir kando, na ritonavir kando. So basically we'll be giving this patient 3TC per daily, 80, 3TG OD. Then we have darunavir as plain molecule, 800 milligrams. Can we give darunavir as OD in this case? Can we give it as OD as compared to giving it as PD?
Yes.
So we can give OD. Anyone from the online participant to assist us make that decision? So it's susceptible. So we can give it OD, it will still work, but 600 milligrams. Then, of course, ritonavir will also give 100 milligrams. So you'll be giving a total of 4 pills. Then let's go to TLD. TLD is 1 pill. So then darunavir is 2 pills. So basically they are 3, but they are better off because if the patient takes TLD, I can't say that. But basically, if your patient is like when you are doing what we call it, the daily witness suggestion, patient is on TDF, 3TC at the you would rather observe them if you are not able to do the BD. No, then is a 3TC at the you're not able to observe them, take the morning pill and then evening pill. You would rather observe them when they are taking the image. So that when they are taking AZT and the ATBR, that is the time you observe. Then when they are taking AZT, you can sacrifice that. But not observe them when you take AZT and you fail to observe when they are taking the full dose. So I don't want to say what I wanted to say, but the TLD plus darunavir is better than giving single molecules. There is also evidence that recycling TDF are shown to work. And not only one study that has supported that, we have around, I think, 3 studies that have supported recycling of TDF. It is still, even in presence of high-level resistance, it is still maintains not susceptibility, but viral replication properties, not viral suppression properties. It is not fully active, but it will maintain, especially when you are giving it with an active support drug. In this case, you are giving darunavir, and we are also supporting it with TTG. So still, for this client, we will give TLD plus darunavir, unless it's a contrary opinion. Someone who want to become controversial. The beauty with science, you cannot become controversial because you must bring the facts. Si kama siasa. Siasa naweza sema unga hata kipanda, kwani watu wanakulanga unga. Okay, so I think we can stop there because there is another thing that is supposed to join this room, unless there is anything burning. I want to stop sharing so that anything. Yes, Kibanda, you want to say something?
Yeah, just aside. Okay, thanks for that presentation. And I was just an observation I wanted to make. Probably, I don't know if you have heard in the past, but I've had a presentation on PK and PD pharmacodynamics, because I was just suggesting that it will be important, because we're dealing with reviewing cases, we are dealing with the drugs, ARVs, multiple classes, and we also would want to know, for example, when you're thinking of the CYP 450 system, is the main one for drug metabolism. But then there are those isoenzymes which one of them you mentioned, 3A4, the others 2A6, and the UGTI 1A. There are several of them.
Yeah.
So I think it would be prudent to just identify the ones that are significant within our scope for care and treatment, particularly for ARVs, so that if we know, for example, 3A4, then we know what are the substrates. If it could be something, a small CME range, basically just limited to the ARVs we have. We know the isoenzyme 3A4, some of the substrates for that, of course, is the lopinavir, tazanavir, and the likes, and DTG. Then which drug induces which enzyme? I don't know if you had a CME on that.
Yeah, that's a very good suggestion. I think it will be a very interesting discussion. We can look for one of our pharmacists to take us through that, just a small presentation so that we can understand which subjects goes with which enzyme from P450, which ARV is metabolized in, for example, in the gut. Because we have some that are metabolized in the GIT.
Yeah, that will be important. And again, as we get into the world of NCDs, getting a lot of NCDs coming into the picture, they are also managed using drugs that you're going to take for long. So we'd want to, again, just know the interactions, what is inducing what and what is reducing what, so that then we are clear. So even when we are formulating regimens, we are very clear when we have complex cases where we have patients who are failing treatment at the same time, they have certain OIs, then we are able to combine regimens that are not kind of counter-checking each other.
Yeah.
Thanks.
Thank you, Kibanda. That is a well-thought idea. You can do that. You can do that. We'll talk to one of the pharmacists within the good thing with Nairobi. We have a lot of specialists in different areas, so we are not sort of getting a good person to do that presentation. Maybe what is the alternative of ritonavir, by the way, just for learning purposes? I'm going to go back. I thought that there's an alternative for, like the one that is used in the Western country. They don't use ritonavir, most of them. They use a molecule called cobicistat. Nani maisikia cobicistat? Yeah, Irina amesikia hiyo amefanya advanced. So cobicistat is that the alternative for Kibanda wanted to answer. I think Kibanda, you want to add something?
Yeah, sorry, I have to say cobicistat, but you already said that. So
okay, so the cobicistat, the advantage of cobicistat compared to ritonavir, it has a better, in terms of side effect, the safety profile is better. Number two, it is selective. When it comes to not induction, but inhibition, it is very specific to the enzymes that it targets the enzymes that we have mentioned that Kibat has, of course, proposed we have a presentation on. So it is very specific compared with ritonavir, which is an inhibitor to some enzymes, while it is inducer to some enzymes. So that is why they prefer using the copolysis, which is specific. I think we can end it there. Unless there is anything that is burning. I don't think our gas is still what let me check. Yeah, Kim is not around, so we don't have a list from Katia. I think they are engaged in other activities. So I can't leave this meeting without emphasizing on the need of the ongoing PMTCT HIV RI. Mumepeana video nini line list. Kila mtu amepeana line list yake. Kwa kuuliza. Watu hivi ni nini? Najua. Tutaona list. Si pale ndio zote. Ndio watu mmepeana nimeona kwa group discuss. Any other? Tarehe. Embakasi list. Ndio siku hiyo ni support gani iko presentation. Ni wangapi umetoka starehe? I think we can end this meeting. Unless there's anyone who wants to speak for the online participants. Jacob. I think we can, yes. Ruth, you can say something. Can you say Ruth, please? Oh, you are appreciating the team. Yeah, we appreciate. Okay, unless there is any other, we can pray, then we do your maneno kujua ni subcontinent gani kutuma representative. Yes, Lucy, you can unmute and speak, please. Lucy, we can't hear you. I think maybe it was a mistake. So we can have someone lead us in our prayer. Our pastor is around. That's what we have to leave. Man, I don't want to go. So to obey, we do some housekeeping, then we go.
Thank you.
Thank you. So I want to do some quick. I want to know which support was not represented so that they can talk to the discuss. So start you wanna mkono wa start. Start ni watu wanne. Langata we have two, so moja kuja. Haya Dagoretti. Dagoretti we have three, full house. Embakasi East. Two, so moja kuja. Embakasi West. Two, moja kuja. Makadara. Moja ndiye alikuja. Wawili. So moja kuja. Then we have Mkunji. Mkunji only one came. We have Kasarani. Kasarani full house. Mpaka wakaongeza wengine wawili. Kasarani we have Westlands. Westlands full house. Saturday. Waraka. Waraka wawili. So that's all the good. So clear. At least each and every sub-account was 50%. Good. So we want to call it a meeting. So that and easy.